Hello, everyone. I'm Dr. Brian Wood from the University of Washington in Seattle. Welcome to the National HIV Curriculum Podcast. This podcast is intended for healthcare professionals who are interested in learning more about the diagnosis, management, and prevention of HIV. Well, today I'm very honored to be joined by two colleagues. Dr. Jehan Budak is Assistant Professor of Medicine here at University of Washington in the Division of Allergy and Infectious Diseases. She provides care at the Madison Clinic, our Ryan White-funded HIV clinic, and is also director of the HIV pathway through the internal medicine residency. She serves as associate editor for the National HIV Curriculum and is an expert in many topics related to HIV and general infectious diseases. We are also joined by Dr. Raka Kumbhakar, who is Assistant Professor of Medicine here at University of Washington as well. She is also in the Division of Allergy and Infectious Diseases, and she is a provider at the Madison Clinic as well, plus multiple low-barrier clinics for people with HIV. She does a lot of really important work to help improve outcomes along the HIV care continuum. Like Jehan, she is knowledgeable in many topics related to HIV treatment and prevention and general infectious diseases. And we learned during the last episode, Jehan and Raka are also now co-assistant directors of our Madison Clinic here. I am honored to be joined again by both of you, Raka and Jehan, and looking forward to this conversation.
Thanks, Brian.
Thank you.
So let's just dive right in. So really this time, I'd like to start with another major, potentially practice-changing abstract that you saw at CROI, something that really hit home for you in terms of the scientific research and findings and something that really could change practice in the future. So Raka, if you would start, what would be your choice number two? Because you gave me choice number one last time. What's choice number two for potentially practice-changing abstract from CROI this year?
So I will pivot from hepatitis B last time to TB and pregnancy. And so there was an abstract called, and again, I don't take credit for naming any of these, Dolphin Moms, which was great. And that was Mathad et al. And what I really liked about this is it talks about two populations that I don't think of so much in my immediate practice until it happens, which is women who are pregnant and who have TB at the same time. And so Dolphin Moms looked at the pharmacokinetics of dolutegravir and HIV viral suppression with either of the short course rifapentine latent TB treatment options, so 1-HP or 3-HP. And what I liked about this is that I think it was really practical, and these are investigators who really thought about a population that is often overlooked or forgotten, and were really systematic about their approach. And they highlighted some things for me just in the background that I don't think about that often and were really jarring. So for women with HIV, active TB risk is highest during and just after pregnancy. We have these short course options, which I'll go into a little bit more, but pregnant women were excluded from the trials of 1-HP and 3-HP, and that's because dolutegravir troughs, we know, drop in pregnancy, and so then they weren't even included. And so then you have daily isoniazid that we're left with for pregnant women with TB, but there's RCT data that there are increased pregnancy adverse events in 6H or 6 months of isoniazid, and so that's led some countries like South Africa to say, just defer treatment for now. But we know active TB risk is highest in pregnancy, and obviously having active tuberculosis in pregnancy is not going to be good for mother or child. And so that's why I really thought this was a nice abstract to highlight.
Yeah, that's a great abstract, Raka. Maybe you can dive in a little more details in terms of the design of the study and the key results and takeaway messages for listeners.
Sure. What happened in this trial, this is a phase 2 RCT of 1-HP. Sorry, I should go back and define these explicitly. So 1-HP is 1 month of daily isoniazid and rifapentine. 3-HP is weekly isoniazid for 3 months with rifapentine. 3-HP comes with daily dolutegravir, and 1-HP has twice-a-day dolutegravir. And this is for women who are not pregnant living with HIV. In Dolphin Moms, they looked at 1-HP and 3-HP in pregnant women and the pharmacokinetics of dolutegravir. So they had two arms. So there was daily 1-HP with twice-a-day dolutegravir, and then arm 2 was the weekly 3-HP with also twice-a-day dolutegravir. And the rationale here is the point I briefly mentioned about the dolutegravir troughs being lower in pregnancy. And so they said, we just have to give everyone twice-a-day dolutegravir up front to test this theory because it wouldn't be ethical or safe otherwise. And so everyone had been on a dolutegravir-based therapy for a month or more with viral suppression. And again, these are pregnant women with latent TB. And because this is a high incidence setting, this is framed as tuberculosis preventative therapy, but analogous here to what we think about as LTBI. And then they looked at PK parameters of dolutegravir in both of these arms. So these were pregnant women who were in their second or third trimester. Their week 1 and day 0 was a randomization at 20 to 34 weeks of pregnancy. Then on day 1, they were initiated on their therapy, and they got a day 1 dolutegravir level prior to their starting the rifamycin, the rifapentine. And then they got a day 1 level. Then they got a day 17 level in both arms, and then they got a day 52 level in the 3HP arm. If you look at this abstract, the plots are confusing because they got a 11 and 12-hour level. And I think to be really specific about when do these peak, and so that they could input these values into their model, which I'll admit the math was far beyond me, but made sense. And so that's what they did to set this up. And they looked at the first 25 participants in each arm because this is a larger, as you can imagine, safety and tolerability trial as well. And then what happened? So I think the big takeaways, day 1, as you can imagine, there was no difference in dolutegravir levels between the arms. By day 17 in both arms, there was a significant drop in dolutegravir, but it was above what we consider in most previous data to be a therapeutic dolutegravir level. That level was lower in 1HP as compared to 3HP, perhaps unsurprising. And then by day 52, there's stable levels. There were just a few people, actually just 2, who fell out of that therapeutic range of dolutegravir, but the long story short is they're pregnant women who had adherence difficulties and were able to correct for that once they were taking their medication appropriately again. So that was exciting. Well, I'll pause and say, I think, Brian, you wanted to ask about the PK modeling, right?
I do want to ask about the PK modeling, but I mean, so far, I really appreciate the points that this is a really important study to do. These are things that are not often included in randomized controlled trials, things like latent tuberculosis, and pregnancy is often exclusion criteria for trials. So just coming back for listeners to the importance of this, thinking about options to treat latent TB during pregnancy, and really this question of what dolutegravir dose is best and can once a day dolutegravir be used. So I agree with you so far. This is very exciting data. And maybe now you can get into the PK modeling, because I think some important lessons came out of that.
Thanks, Brian. So I think, as we'll remember, in the way they've set up the trial, everyone is getting twice a day dolutegravir, right? But then they used their dolutegravir troughs to say, what if we simulated what it would be like to give daily dolutegravir with both regimens, both the 1HP and the 3HP. And so for the 1HP in their simulation, unfortunately, this wouldn't work. All the dolutegravir troughs would fall below target. But in 3HP, they all remained above target, so they were therapeutic. And so this is, again, PK modeling, but it was enough to suggest to them that it would be reasonable to trial, and then ongoing in the trial, daily dolutegravir with the 3HP arm, not the 1HP.
So just to summarize that, so promising or potential for daily dolutegravir dosing with 3HP, but as far as they could tell from the results in their modeling, with 1HP, twice a day dolutegravir is probably, or is what they suspect will be necessary. Did I understand that right?
Yeah, that's right. And I think they won't even test the theory in 1HP because it was pretty convincing. And again, remember, this is still the recommendation in non-pregnant women, so it's perhaps not surprising, but it's great that they tested the theory. But they'll go on and say, what if we can test daily dolutegravir in 3HP?
Got it. So more data coming in the future.
Exactly.
Rock, I appreciate that a lot, and really glad you brought up this topic for us to think about. It is very important. Rocka, for time, I'm going to switch gears, but I appreciate that a lot, and I'll be flipping back to you here in a bit. Jehan, I have the same question for you. You gave us number 1 top pick, abstract from CROI, last time we talked. What's your pick number 2?
I think I'll talk a little bit about the doravirine islatravir studies, which were 2 paired oral abstracts. The first one was presented by Coulson, and that was number 204A. And then the second one was presented by Dr. Chloe Orkin, and that was 204B, about this combination as a single tablet. option. And so I think as background, islatravir is an NRTTI, which stands for a nucleoside reverse transcriptase translocation inhibitor. And a couple years ago, it was being studied, but as we might all recall, it had to be halted due to drops in the CD4 count and the total lymphocyte count, which was attributed to the islatravir. And my understanding of that is that it was a dose-dependent issue. It was reversible. And then they decided to sort of redo these studies after what seemed like a long time, even though I know it wasn't a long time, but we've been waiting to see what's going to happen with islatravir. And so they redid these studies with 0.25 milligrams, whereas in the previous studies where we had seen those issues was 0.75 milligrams. And I was curious as to why that was happening. And what I was able to find out was that islatravir, I think triphosphate, accumulates in the lymphocytes and then actually causes an apoptosis, which is why the cells were decreasing. Anywho, so what they did here was, again, just repeat the studies with 0.25 milligrams of islatravir paired with doravirine. And so these, as I mentioned, two studies both had about 500 individuals with HIV who were virologically suppressed. The first study was a double-blind study where people were on TAF, FTC, and bictegravir, or BF-TAF, and there were randomized 2-to-1 islatravir doravirine or to continue on their current regimen. And then the second study was an open label study, and the people were on baseline ART. And from what I recall, about 64% of those individuals were on an integrase-based regimen. Similarly, randomized 2-to-1 to being on islatravir doravirine versus staying on their baseline ART. And the big takeaway point was that the viral suppression rates were similar and thus was non-inferior. And I think what was significant about this is, I believe, is that initially when things had to be halted after the 0.75 milligram dose was causing issues, I think people wondered, how potent will 0.25 milligrams be? And in fact, seems that it was potent enough. So that was kind of a big deal.
If I'm hearing correctly, so this lower dose of islatravir seemed to retain virologic efficacy when paired with doravirine and did not have the deleterious effects on CD4 count or lymphocytes the higher doses did. Is that correct?
Correct, yes.
So this is the potential for a switch therapy to a 2-drug combination, doravirine, islatravir. So the question in my mind, let's start with who might be good candidates for this potential switch in the future. Who are you thinking about in your practice? And then as a corollary, one thing I've read about doravirine and islatravir is it is postulated that both drugs are fairly metabolically neutral. They may not stimulate excess weight gain or metabolic complications, which is a concern that's been raised in recent years with some other antiretroviral medications. So can you go a little bit more, Jehan, into any metabolic outcomes from the studies? And then who are you imagining in your practice might be good candidates for this 2-drug therapy?
Okay, so first is the metabolic stuff. So I think to your question, Brian, my understanding was, at least it was in the study where they were comparing things to the baseline ART, not to the BF-TAF. They did notice that with removal of the baseline ART, there was some weight gain in the DOR islatravir arm. That being said, my understanding was that that was because of removal of either TDF or efavirenz. And so thus removal of the anorectic medication then led to some weight gain. And then I remember seeing an image where they compared if you weren't on tenofovir or efavirenz, and then it was weight neutral. I do think of this as a relatively weight neutral medication option. And then to your second question about like, who are we going to use this in? And in fact, I think Raka and our other colleague came out of the oral abstract and were like, well, who are we going to use this in? And I feel like we were talking about this in the cafeteria as well, where it's like, who is the person going to be for this? I think as the investigators pointed out, it's the first 2-drug regimen that doesn't include an integrase inhibitor, right? Like the other 2-drug regimens are dolutegravir 3-TC, dolutegravir and cabrilpivirine. And so this is one that doesn't include that. And I know, and to your point, there has been discussion and concern about potential metabolic effects with maybe some of the integrase inhibitors. And so this would be sparing of that and include that. So I think it could be a weight neutral option. is one thing. And I think for me, and this is by no fault of anyone's, it's just that like I would like to see a little bit more observational data with regards to islatravir of like how durable is it? I know it's potent enough, but like what's its barrier to resistance? How is it in real life? So that I can get a better sense and get more familiarity. But I would like a little bit more observational data before I start using this combination in individuals to really figure out what its point is going to be. And I think because we had to wait a little bit more for the new data at the lower doses, we just don't have that information yet for me to figure out exactly who I'm going to be using this single tablet regimen, or this combination of meds in. Also, too, I think they're going to pair islatravir with other medications as well. And so we'll see what its role is there. And, if it's not here.
Absolutely. And to add to that, I think it may end up being that we see islatravir paired with other medications that could have lower dosing frequency, potentially even once per week dosing, for example. Is that correct?
Yes. And in fact, at CROI 2024, there was a poster, I believe, about weekly islatravir with weekly lenacapavir, if I recall correctly. And I think there are some other things out there too.
So potential for new two-drug combinations that do not include an integrase inhibitor, maybe a little further down the road, potential for two-drug options, a switch therapy that even has less frequent dosing and may not require taking pills every day. So a lot of promising potential here.
Yes.
Jehan, this is great. Okay, I'm going to move us to the next segment of this. And really, what I'm asking for here is less of a deep dive, but more quick hits, if you will. Rock, I'll turn to you next. What would you take as a quick hit takeaway that listeners should be aware of?
So staying on the TB theme, there was a poster by Pofu that was poster 646 that I thought was really interesting, that basically proved our point that it is okay probably to use TAF with rifampicin-based TB therapy. And I think this is important because many people will say, duh, or we're already doing that, or there's higher intracellular concentrations of tenofovir with TAF than TDF. We already know this. But the FDA label still says don't co-administer TAF and rifampin. The OI guidelines say you can do it, but monitor closely. And what this study looked at was they looked at PK on people who were virally suppressed on rifampin-based therapies, and they did sampling of intracellular tenofovir when they were on TDF plus RIF, on TAF plus RIF, and then at the end when they were on TDF alone. And throughout all of that, the intracellular tenofovir concentrations were highest in TAF, even though recall that was with RIF, it was still even higher than TDF alone. So I think that's really reassuring to me that that study had been done, or a similar study had been done in healthy volunteers without HIV, but to say, hey, look, they're fine, their intracellular levels are fine, they remain virally suppressed. I think that's really compelling, especially as we ask people to change around their regimens while they're getting treated.
Absolutely. So have you done this yet in clinical practice? Have you prescribed TAF with a rifamycin?
I think what has happened is I've opted not to change someone's TAF-based therapy. I think what we more often run into, as you know, is the integrase issue. And so if someone is on big TAF FTC, we still run into the issue of the bictegravir level. So I'm still switching people off of that regimen onto a TDF backbone. But now I think there's been a couple of cases where we've paused because someone needs TAF versus TDF because of a renal issue. And so now I feel a little bit more compelled to say, hey, we can do this. You don't need 6 months of isoniazid. You have a few more options available to you.
Some reassuring data that if someone is taking, let's say, TAF FTC as their NRTI backbone, there's a reason not to switch it, or it would be challenging to switch it, that prescribing it along with a rifamycin for LTBI or TB treatment really looks like it should be okay. And as you mentioned, the OI guidelines say if you do that, maybe monitor the viral load a little more closely. But really, this is reassuring that that combination should be fine. Am I hearing that correctly?
Yeah, that's exactly how I'd frame it.
I agree. That is a very potentially practice-changing research abstract. So that's great. I'm glad you brought that one up. Jehan, I'm going to turn to you. One or two quick hits, faster, more lightning round. What do you think listeners should be aware of?
So this is not necessarily practice changing per se, but I think it's been helpful to see what's been going on with injectable CAB rilpivirine. And in fact, since it's been FDA approved in 2021, we now have enough data that there were actually 2 abstracts talking about why people stop using CAB rilpivirine. And so that one was Kat Christopoulos, and that was, I believe, poster number 683 from Ward 86 data in San Francisco. And then Fagiano had a poster from the Owen Clinic at UCSD, and that was poster number 685. Both were retrospective cohort reviews of about 450 people with HIV that had been on CAB rilpivirine. I think the Ward 86 group had about a year and a half worth of data, and then the Owen Clinic had about half a year's worth of data. And interestingly, about maybe 16 to 20% of people had actually stopped CAB rilpivirine after having initiated it. And the main reason for discontinuation was injection site reactions, but also logistical issues coming in, planning, scheduling, et cetera, were another one. And I think that's, again, this is just helpful because we have some observational data about what's going on as people are using this medication. And though there is a lot of satisfaction with it, there's a decent number of people who are actually stopping because of the injection site reactions. And so it was just helpful to see.
The lesson I take from that, and maybe listeners can take, is if you are gearing up to prescribe injectable cabotegravir rilpivirine, counseling individuals about the potential for injection site reactions, having a plan to help to minimize those, to help if they do occur, I mean, really is an important part of the therapy. Jehan, do you have any anecdotes from your clinic and your practice of any strategies that help to reduce the painful reactions or help if someone is experiencing them?
What I've heard is stuff like, hot compresses, using over-the-counter NSAIDs, maybe some ice. And then I've also heard some people doing squats the day of, in which I think physiologically makes sense to me, to maybe get blood flow moving, and doing many squats over the course of that day to help mitigate that. And so I think that's one thing. And I think we've seen some people here stop due to injection site reactions. I'm not saying that 16 to 20% of people stop because of ISRs or injection site reactions. It's just that 16 to 20% of these people in these cohorts stopped for a variety of reasons. ISRs happen to be the big one. And I think what is really important for patients to know is that when you're starting an injectable antiretroviral therapy, it doesn't necessarily have to be a forever thing. It can be a part of their life. It's not a destination. It is just something that they can be on for a short amount of time and may not be forever. And that's okay.
Yeah. Oh, that's well said. And if an individual has trouble tolerating it, they can talk to their clinician about a transition back to oral ART.
Yeah. Just like any other medication. Yeah.
Absolutely. This was great. Again, I think really helpful to hear potentially practice-changing research abstracts from the conference. I'm sure there are many, many more we could have talked about, but it sounds like these are the ones that stood out to you the most. So Jehan, Raka, I want to say another huge thank you for sharing your time with me today.
Well, thanks so much for having us.
Thanks, Brian.
Thank you.
Transcripts and references for this podcast can be found on our website, the National HIV Curriculum, at www.hiv.uw.edu. The production of this National HIV Curriculum podcast was supported by Grant U10HA32104 from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the University of Washington IDEA program and do not necessarily represent the official views of HRSA or HHS.